Without wasting much time, let's move on to the next topic, which is labor management in pre-gestational diabetes. With so many diabetes patients we are seeing day-to-day practice, a very good, important topic for all of us to know. And to talk about this, we have none other than Dr. Nuzhat. And to moderate the session, we have two professors with vast experience in the field of diabetes. That is Professor Chellama, retired professor from Calicut Medical College. Now she's the professor and HOD of KMCT Medical College, Calicut. And she has got special interest in diabetes in pregnancy. And the other moderator is Dr. Lalitambika, professor and HOD, Government Medical College, Alappuzha. Madam is the president of Alappuzha OG Society also, and she is the past president of CAREFOR. And to speak about this, we have Dr. Nuzhat Aziz, head of Department of Obstetrics, Fernandez Hospital, Hyderabad, with a special interest in high-risk obstetrics, protocol making, prevention of stillbirths, and also the growth charts, the customized growth charts. Over to you, Dr. Nuzhat, and the moderators. The platform is all yours.
Good morning to all of you. The next concept is labor management in pre-gestational diabetes. I think they have given more importance to the pre-gestation rather than the gestational diabetes mellitus. So we know that in Indian context there is an 11-fold increase in the diabetes or glucose intolerance during pregnancy, and we know that it is pregnancy is a diabetogenic effect, and also there are a lot of complications, especially maternal and fetal complications, especially when there is pre-gestational diabetes mellitus, and especially we know that there is uncontrolled diabetes, there is more chance for macrosomia and shoulder dystocia and related birth injuries and lot of neonatal complications. So it is very important to have a good intrapartum care of diabetes during labor, and this is very important to prevent the complications. So we will hear from Dr. Nuzhat regarding about the labor management in pre-gestational diabetes mellitus. Over to you, Dr. Nuzhat. And my co-chair, Dr. Ladambi, is there.
Very good morning, all of you. As Dr. Chellama has already mentioned, pre-gestational diabetes, now the incidence is increasing because the maternal age is increasing, and more cases of pre-gestational diabetes are being encountered by us. And as we know, the complications are more in case of pre-gestational diabetes, and also intrapartum management is really challenging to us compared to the gestational diabetes mellitus. So over to Dr. Nuzhat. We are eagerly waiting for your talk.
A very good morning to each one of you, and thank you so much, Mumtaz, first of all, for this privilege, and it's indeed a pleasure to be a part of the POGS conference over here. To my chairpersons, Dr. Chellama and Dr. Lalitambika, a big thank you for that introduction. Now, over the next 15 minutes, I'm going to take you through the labor management in pre-gestational diabetics. We'll try to make it as practical as possible because there is so much of theory, but how much do we use it and what is essential for us? I would also like to show you our standard of care in our hospital. We are slightly different from others, but has been having a good outcomes. So my perspective would be, I would be aiming to define criteria, targets, and what should be our first response when there is a deviation. But I would like to have a disclaimer that I'm not an endocrinologist, would never be able to advise an insulin therapy for any person, and cannot manage deviations, but would be a good person to respond for any kind of deviations from normal. Now, just to give you a background of where we come from, Fernandez Hospital is a tertiary care center. We do about 10,000 births annually. And if we take a look at diabetes in pregnancy, we have about 25% as incidence. Most likely it's a tertiary center, but 1 in 30 deliveries would be a pre-gestational diabetes, and we had about 348 pre-gestational diabetics in the year 2019. And I'm just substantiating with few of the numbers, and that would make 3% of our total births. Out of them, we had 4 stillbirths, giving you almost 10 to 11 per thousand stillbirth rate. And we had no neonatal deaths, and our incidence of neonatal hypoglycemia requiring admission in this high risk group is 4.3, which is very good when compared to what we have in the other standards. Now, just to give you a kind of an overview of where we stand with pregestational diabetes compared with GDMs, then definitely the stillbirth rate is higher here, and only one stillbirth at 34 weeks. The remainings were too small, maybe congenital anomalies, which we were not able to prevent. That is one. But the care of a diabetic woman in pregnancy, or the protocols that you have, will be judged by the incidence of LGA in that series. And at this point, I would like to show you that we have an incidence of 14% LGA in this group, and the remaining ones are very close to 10, and that tells you how good is your antenatal management of blood sugars. And the average birth weight for Fernandez Hospital stands at 2.8, and we are standing at the same birth weight for pregestational diabetics, and this is what tells you and manages you through. And if we take a look at the adverse outcomes of diabetes, and as Dr. Chilama said, there is a series of every possible adverse effect that you can think of, and all of them are related to high blood sugars. If you control them, then you can decrease the incidence of most of them. What do you mean by a tight control? We have to remember that these numbers are to be taken seriously. A fasting blood sugar of less than 95, 2 hours post meal of less than 120. It doesn't mean that 95 can be 105 or 120 can be 130. It's a grace is not allowed over here, because even 122 was found to be associated with higher adverse outcomes. When we talk about pregestational diabetes, it is important to remember that we are talking about two different entities in this. One is type 1, where there is no insulin and you have to supplement insulin from outside. Whereas in type 2, you have insulin, the receptors are not very sensitive enough, and you have to increase their sensitivity and push the glucose inside. So they are basically type 1 and type 2 are very different entities when we talk about management in labor. I'm just going to put in a clinical scenario to make it a little comfortable. She comes at 2 centimeters. She's type 1 diabetes and spontaneous labor. What are your concerns? Now, when we talk about management in labor, we have maternal well-being, fetal well-being, and progressive labor. Now, moving across to fetal well-being, it's a high-risk pregnancy. You will monitor her the way you would as protocols. No changes from a high-risk pregnancy protocol. Progress of labor, there are no changes. What is our main concern is maintaining her sugars, and also to avoid hyperglycemia, ketosis, maybe infection, neonatal hypoglycemia, and birth injuries. Birth injuries will be higher when the LGA incidence is higher. Birth injuries will be lesser when the LGA incidence is lesser. Again, moving on to your antenatal control. Now, how do we move forward? Very important that we need to take a good history at admission. What type of diabetes am I dealing with? What is the current insulin regimen? Okay, whether she is on long acting insulin, which is going to have a 24-hour blood levels, time of last meal, and last insulin dose that she had. What is your current GRBS or capillary blood glucose? What is the gestational age? Because prematurity is associated with a lot more sequelae for the baby. AGA or LGA, then these are definitely LGA babies have problems in intrapartum labor when compared to AGA babies. When we check her glycemic control, most of the blood sugar charts are given to you this way. They monitor them patchy, and you have plenty of values, and you really don't know what is good control and what is not good control. At our hospital, what we do is we highlight the hyperglycemia with a yellow highlighter, and we put in a kind of a box, a red box, and I find it convenient for hypos, which will just tell you how many hypos and how many hyperglycemia episodes I have in this chart, and it allows you just a practical point for you to have them. Now, the question is, why do we need to ask such questions? Good control in antenatal period is going to give you a good sustained kind of blood sugar levels in the intrapartum period. If the total amount of insulin per day is more than 0.5 units per kg per day, then you are going to definitely require insulin in the intrapartum period. Type of diabetes, type 1 requires insulin, whereas type 2 can be managed with a lot of other things. Okay, phase of labor, latent phase versus active phase of labor. All of us obstetricians, we may not be dealing directly with prescription, but we need to know if the patient was on insulin Lispro, what is the duration of action. It helps you have an idea about how long is this insulin going to act. Now she's in latent phase of labor, or you can have an induced labor. She's put on a diabetic diet. Not much of a change, except that we change her insulins to Actropid. Okay, pre-meal sugars are done, and the endocrinologist is informed, and she's monitored. You can always have a monitoring chart which is convenient to your needs. For us, in the early part of labor, IP patients, we have a blood sugar chart, which is, pre and post meal, and also what kind of insulin dose. And this allows you to have a kind of a watch over her stay in the hospital. Now the problem starts when she goes across to the active phase of labor. The active phase of labor is the time wherein your demands for glucose as well as insulin change rapidly. So we start blood sugar monitoring levels, and frequencies every hour. Especially in type 1 diabetics, we use a sliding scale of insulin. The question at this point of time, and I'm sure why this talk has been asked for, is which regimen is good? What is the insulin infusion cutoff that we should start? What are your targets? Which one is best? Now, before I go into type 1 diabetics and labor, I want to just breeze up a little bit about general labor. When we talk about general obstetrics, we know that the amount of work done or the physical endurance is extremely high. If you want to compare with an unduly heavy exercise for men, you will go for 10 METs for both men and women, not as high as labor and birth, which has been put as 12 METs. So it is much more higher than heavy physical activity that you design anytime. We also know that if we restrict food and drink, we have an association with accelerated starvation, ketosis, and a lot of other things. And when they tried giving glucose during this time to reduce the ketosis, they found that it was not good for the baby. When we did a small study of 200 women in Fernandez Hospital, and we wanted to see what is the effect with oral fluids, we were giving oral fluids. We found that ketosis developed very rapidly over a short period of time. And hence, we have become much more liberal in giving them snacks in between, sandwiches in between, or if they want to take anything. And we only limit to fluids in the active phase of labor, which is defined as 6 centimeters or more. What happens in exercise, we need a lot of glucose that is needed by the muscles, okay, and for this the insulin secretion decreases and the glucagon secretion increases. Now what happens in diabetes is that you have a baseline level of insulin, and your glucose is what you have, okay, some time back. So you find that glucose levels will decrease with aerobic activity, it will increase with anaerobic, and it will be fluctuating in between if you have a mixed activity. You have to remember this, that the person's insulin is dependent on the dose of insulin that they have taken or the baseline level. You can skip insulin before doing exercise for type 1 diabetics, but it leads to hyperglycemia and ketosis. So it's a very fine balance for us to to give glucose to an insulin to avoid hypoglycemia, to avoid ketosis, and avoid hyperglycemia of the level of more than 126, which is going to give rise to neonatal hypoglycemia. So this kind of a balance is very essential for these women. What is the time when they actually require more of focus? It is during the active phase of labor that the glucose goes up very high, and the elevations are seen. So we need to concentrate on this time. What should be the cutoff? Now, I couldn't get a direct correlation type of, and I was been searching for any kind of a graph which will tell me that if you put it at 100, it's going to be this much. If you put it at 140, it's going to be so. But the suggested levels are 70 to 126 or 4 to 7 millimoles coming from NICE and ACOG. Now, I would like to just show you what is the regimen's advice. We at Fernandez follow similar to rotating fluids protocols, a little bit like the one which is, I'm going to show you the modifications that we have made. We do a capillary blood glucose every hour for type 1 diabetics, and type 2 diabetics, if they are very well controlled, and GDM, we go for every 2 hours. And if the value is more than 140, insulin infusion is started. You can lower down this value to 130 also, but insulin infusion is started at more than 140 milligram per deciliter. Now, in the other protocol, which is suggested and most widely used is insulin infusion protocol, is a mandatory start of dextrose saline plus an insulin infusion for this woman. And it is started when the glucose levels are more than 81 milligram per deciliter. And the aim is to maintain it at 100 milligram per deciliter levels throughout the labor. Now, what were the findings? They found no difference in the mean maternal blood glucose levels as well as neonatal hypoglycemia on both the sides. They also found that there was no difference between tight and liberalized control. Okay, they did definitely have less of maternal hypoglycemia or hypoglycemia, but not much. There was no difference between tight control and routine control. This is the latest one that I could find in September 2019. And it talks about type 1 and type 2 diabetes with no difference. What is the very essential about these studies is that if we take a look, we find that the neonatal hypoglycemia in the series is extremely high. And if you take a look at the LGA rates, it's 48% and 23%. Half of their babies are LGA. Now, you have a doubt